Good morning. How's everybody's morning started? Did everybody get some breakfast? Yeah, good. So I'm Anne Marie Cooley. I'm Senior Director of Clinical Development at Smith&Nephew. Welcome to our sunrise session titled Leveraging AONL Leadership Competencies for Pressure Injury Prevention. And I'm here to introduce our speaker, Robin Gasparini, DMP, MSN-RN, ACNS BC. Dr. Gasparini is a nursing administrative specialist at Mayo Clinic in Jacksonville, Florida, where her focus is strategic planning for the Department of Nursing. In this role, she leverages improvement science to advance nursing outcomes. Educated as a clinical nurse specialist and with a doctorate in nursing practice from Duke School of Nursing, Dr. Gasparini brings nearly 20 years of practical experience in critical care and cardiothoracic surgery. She has a particular passion for patient and family-centered care delivery. It is my pleasure to introduce our speaker, Robin Gasparini.
Good morning. Thank you so much for getting up and being here and for your interest in this. So I appreciate your time and know what a commitment it is to get up for a sunrise session. Anne Marie makes everything sound good, but I'm happy to be here and really pleased to highlight the great work that we've done in our organization, but more importantly, just the leadership competencies that it really takes to be able to leverage a great tool and get those amazing outcomes that we're looking for in our organizations. So it is a small group. Please ask questions, and I want to make sure you're getting what you need out of this morning's session as well. Yeah. To disclose, I am a paid consultant of Smith&Nephew for this presentation, but the information that I'm sharing today are my findings and should be used for education purposes. But this is something that we have found in our organization and that we leverage and that we very much believe in, or we wouldn't be here. So I think that we'll go through a little bit of data just to explain the why before we get into some of our leadership competencies. This information likely is not new to you, but should really help kind of explain and bridge that gap that's so important for us to be transparent about when we talk to our staff. Pressure injuries are, when we think about our hospital-acquired infections, we've done a really good job, particularly up until 2019, reducing rates of hospital-acquired infections in our organization. So, things like adverse drug events, our C. diff rates, CLABSIs, CAUTIs, all have had significant reductions, a lot of work group efforts to reduce those. Sadly, hospital-acquired pressure injuries are the only hospital-acquired infection that are on the rise, and AHRQ estimates up to over 6% increase in the last couple of years. Now that data is from 2019, so we all know what COVID did to our organizations. We saw some increase with our hospital-acquired infections, but they were very population-specific. However, the pressure injuries were very general across the board. In fact, when we a survey that looked at 110 different nurses found that 43% of nurses indicated that they weren't following their turning protocols, and citing things like our staffing and other challenges as things impacting their standard of care. So when we look at pressure injuries over the last couple of years with COVID, there's not much difference in where these injuries are occurring. We're still seeing a lot of those sacral and bottom pressure injuries that are resulting from lack of turning and movement, so things like heels, et cetera. We're only seeing less than a third related to proning or COVID, more around the facial pressure injuries. Interesting studies there. It's really hard to capture the cost of a pressure injury, but when a particular study looked at over 9 million patients and was able to isolate factors that impacted patients with pressure injuries, what they found was an average cost of over $20,000. We know that they have longer ICU or longer length of stays in their hospital. And then these patients are also more likely to experience a readmission either within 30 days or 180 days. So all things that have a pretty big impact on our organizations. And, again, that's just the tip of the iceberg, right? So we understand the impact it has on our nursing sensitive indicators, our clinical operations, and not to mention those indirect costs, things like our fines and penalties, the litigations that we would be scrutiny to, and not being reimbursed for the treatment thereof of those pressure injuries. And those are all things that impact our organization, but this is an undue burden on our patients. That it's something that should really be a never event that a loved one should never have to experience. So in 2019, the International Pressure Injury Prevention Guidelines were modified outside of just that routine turning schedule that we're all so familiar with. So they're citing that the new standard of care should really be an individualized turning schedule, one that achieves that optimal offloading that we're looking for. And they've added a component about a reminder strategy or something to help staff adhere to turning protocols. And they listed a few options there. So really interesting, guidelines saying this should be a part of our everyday standard of care now. Fun fact, because we're approaching Nurses Week, Florence Nightingale actually was instrumental in developing our turning protocols. In fact, the first known kind of turning strategies came from Florence during the Crimean War, when she would go through the ward and turn one patient at a time and then start over, right, and provide that manual manipulation. And so that's really where we get the origin of our turning protocols. And if you talk to nurses today, everyone understands that any allied health staff, right, that turning and Q2 turning is what helps prevent our patients from developing those detrimental injuries. However, we're just not finding that it's consistently being done, right? We think about the challenges and the stress, the day-to-day, the tasks that the staff have to do, and if they're able to complete those. And it becomes quite a challenge thinking about, every patient, the different turning schedules that they're on, being able to communicate and articulate those tasks to peers and actually achieving that. Oh. So data actually shows that we're not adhering to our turning protocols. This is a large study that was done, and you can see some outliers here, but an average of 48% of the time we're only turning our patients. That's less than half of the prescribed time that we should be turning patients in the hospital, right? So, really interesting data here indicating that it's just not occurring. We also know from studies that our patients don't receive the same level of care. There's a lot of variability between day shift and night shift. So individuals on night shift are positioned much less frequently than patients on day shift. And I think that there's also a lot of unintended biases that we found from these studies. So patients that have a higher BMI, even gender, impacts whether or not patients get turned. So we know that patients with a higher BMI are much less likely to be turned. And those are patients that are really at risk and need that extra support. And I truly believe these aren't intentional actions that we're finding. These are those kind of unintended consequences, those unintended biases that we have when we provide care and the time that we have to do that daily. In addition, we know that nurses have to document a lot, right? So there's a study recently that indicated there's over 600 data points that nurses have to document each day, which, we know that burden. We know why that's important. But to set our staff up for success, we really have to think about ways that we can integrate that documentation and streamline that documentation for them. And if any of you have ever done, and I'm sure you have if you're in this room about pressure injuries, root cause analysis to understand what's going on with your patients and if these patients are being turned and why we have pressure injuries and kind of where our gap is that we can improve, then you've looked at patient documentation around turning. And I don't think any one organization is free of that, right? We know there's documentation gaps, which put us at risk. The reality is that documentation, these nursing interventions aren't something that are automatically documented, and they're not documented in real time. And so that creates a jaded record, if you will. We tend to go back at the end of the shift and try to put in those documentation turns, right, or the nursing interventions that we've provided because it's not already in the record. We know this takes about 25% of staff time, which is just a lot. So really thinking about how we can streamline and set those teams up for success. And so that leads us to the device that I'm here to talk to you today about. A wearable sensor from Smith&Nephew called the Leaf that is a easy way for staff to have visual cues that are silent, they're not audible, they're easily translatable, and notify our teams of turning. So it's a turning cue system. What I really like and value about this system, particularly in our organization, is that this is not just a turning or 2-hour timer, right? So as indicated by our 2019 new guidelines, International Pressure Injury Prevention Guidelines, this isn't a reminder. In addition to it being a reminder, it looks at the patient's center of gravity. So it sits on the patient's chest, and it monitors the core center of gravity. So it's looking for those quality turns in addition to monitoring time. So nurses or allied health staff can get immediate feedback about the care that they're providing and know that that patient's in a turn angle that meets that patient's need or is individualized. And then it's got smart technology built into the sensor, so it's not just that 2-hour timer. It's calculating the patient's movements because it is on the center of gravity. If a patient's able to turn independently or move independently, if an early nursing intervention has been provided, the patient's boosted in the bed or needs a new pad or is turned for whatever reason, and then goes back into that position, the sensor calculates time back to that patient on that side, indicating that reperfusion has occurred. So when the notification for turn occurs, it's only notifying staff when a manual manipulation is due or required for reperfusion. So it's really saving staff time. It's not just that 2 hours. It's notifying us when turning is required for reperfusion. The system's able to give us a lot of data, and so this has been really helpful for us in our organization looking at quality improvement. So we can see information and data for each patient on an individual level, or we can see data for our entire unit. It allows us to put quality safety nets in place for the data that we're seeing. So if our sensor utilization seems off, if our numbers don't seem right compared to the population that we have, our wound care team is able to kind of round and work with our staff and look for those patients. We're able to see that we have a much equalized turning distribution with patients. So it's not just right back, but we're really seeing, a third, much more equalized distribution for protection of our patients and skin. And then we're able to look at things like reduced turn angles, and our clinical nurse specialist team is really able to see where we have gaps with data that we pause, or if the turn angle is reduced for a patient so that they can support teams with things like hemodynamic instability with turning, et cetera. We'll talk more about that. So what we know about leveraging this device is that it helps improve our compliance with turning. So before, if you remember, we average our turning compliance to be less than half of what's prescribed, right? About 48% of the time on average. But leveraging the sensor, we're able to see an average turning adherence about 92%. In addition to the turn adherence, we're seeing much less variability, right? So patients are getting turned much more consistently across the board. So this is showing us over time, day shift and night shift, that reduced variability in care. In addition to reduced variability, we're seeing more diverse care, right? So we're applying those turning protocols to all of our patients much more consistently, opposed to having some of those unintended or unknown biases that might be at play. And then in a large randomized control study with 2 arms done at Stanford University, looking at just under 1,400 patients for over 100,000 hours, indicated that with increased turning at 92%, we were able to achieve a 73% rate reduction in pressure injuries. So really significant reduction when we adhere to the standard of care that we know supports our patients. This is a study that was actually just published this month in Acute Care Nurse, so look for this, but really interesting work done here looking at documentation efforts leveraging the sensor. There was a manual group indicating that when they looked at patients and the number of hours, that documentation for turning or adherence to our pressure injury prevention bundles was only about every 6.5 hours, so only once a shift. But when we leveraged the sensors as part of the bundle, we were seeing a much improved compliance with our documentation. So increase of 165%, but really every 2.5 hours to get that documentation. And then when we look at the impact on those biases that I talked about and the ability to care for patients more equally, patients prior to using the leaf sensor were really showing that if you had a BMI of greater than 30, we were turning those patients about, on average, once per shift, every 9.5 hours or so. And you can see here a pretty broad variability based on BMI. But when we add that sensor utilization, we're getting that much more consistent care delivery, and it's much more frequent of about 2.5 hours. And our patients who are more underweight, they actually had a less turning frequency of about 3 hours. But I think those are the patients that we think have some of that independent mobility, and that's where we have the sensor utilization telling us that these patients don't require a turn because they're moving themselves, right? So the sensor's really notifying us only when those turns are due for manual manipulation for that tissue reperfusion. So much more consistent care delivery. When I think about this tool, this tool has been great for our organization and the results that we have achieved. When I think about what it takes to implement a tool and leverage a tool, it's a tool. And so we really give our staff credit for being able to leverage the tool the way it's intended and drive those results. So it's the staff doing the work. But there's a lot of predictable behaviors that and emotions that staff feel with new technology. It's change, and it really requires strong leadership and change management to be able to execute a new intervention such as this or a new standard of care. And so that's what I want to talk a little bit about, is really how we can take a tool like this and get good results, but how it's our leadership and support that can really move us from good to great and get amazing results. In our organization, we were not where we wanted to be as far as our Indian QI nursing sensitive indicator, right, for pressure injury prevention. And so this tool has really helped us move 4 percentile rankings to achieve the results that we wanted consistently. But it really took a lot of assessment of where we were and what our underlying culture was around turning. And I think that's something that's really important when we talk about this tool. Is it is a tool, and it helps us achieve our standard of care, but it also highlights the things that we didn't know were a concern, right? So we had done so many root cause analysis in our organization. We looked at every pressure injury that had been developed for a year, and we still didn't understand the culture that we had in our ICUs around patient turning until we leveraged the sensor. And the data that we were getting from the system really helped show our gaps. We learned very quickly that we weren't turning our patients as much at night, even with the sensor. And we were struggling to understand that. When we did a deeper dive, we realized that our ABCDE prevention protocols, our delirium prevention protocols, our do not disturb, had really been maybe misunderstood, and we were not bundling our care the way we should be at night, and we were failing to provide some of the key interventions our patients needed, including manual manipulation. So the sensor was able to highlight that for us. We also noted a lot of reduced turn angles or lack of sensor utilization. And so when we would talk to our teams about that, there was really a sense or a feeling that maybe the tool was a great tool for some patients, but it wasn't appropriate for our patients. And that's a big statement from staff, and honestly, the most concerning for me, right, if we think that our patients aren't good candidates for something, related to pressure injury prevention. And so when we did a deeper dive, it was really because we have acutely ill patients. If you're in the hospital, right, we know that patients in the hospital today, with the resources we have for home care, are quite sick. So the acuity is high. And our teams really struggled with turning patients who were really ill. Hemodynamic instability is a very real concern, but the only way that you combat hemodynamic instability is with those micro turns. So being able to provide the resources at the bedside to the staff to do the micro turns with the patients and see the hemodynamic stability in a very safe and controlled way to improve those patients' outcomes was really important for us to understand how our staff are feeling and then invest in those resources to support them and ultimately get the outcomes that we needed. And that culture and that behavior was something that wasn't very clear to us until we could really see our unit level data. But it was really important for us as leaders to be transparent and talk about what we were seeing and why this was important, and use that data to impact our teams. As you can maybe imagine, leveraging a sensor like this sometimes feels a little bit big brothery, right? So our teams felt like maybe the data would be used in a punitive way if their care wasn't being done. We know in busy times when nurses in particular are taking the role of respiratory therapist and phlebotomist, with increased census and low staff volumes, when they're doing it all, that the easy thing to do is to let some of those simple tasks go to the back burner, things like turning, things like changing the linen and doing baths. All things that are very, very important for our patients' care, but that our staff aren't able to do. So the system helps us look at that. It's a reminder that things need to be done, but staff feel like they might be penalized or that it's watching them, right? And so using the data in a positive way to highlight the outcomes that we have as opposed to using it in a punitive way for staff who weren't getting their work done. Certainly not the intent. Really being clear about why we're investing in this system and the data that we're seeing and why it's important that we protect our patients and all the ramifications that it has. I'm sure you can imagine a lot of staff questioned why we would invest in a tool like this as opposed to more FTE. Not always an easy answer, right, to just magically get more FTE in your organization. But investing in this device for us was a way to show them that it was really important for us to invest in tools that would set them up for success and all of the reasons why we thought this tool would do that, and how more staff wouldn't do that. So this was an FTE neutral operation for us, which was also really, really important. And staff can understand that, but it really takes a lot of transparent conversations and consistent conversations from top down about what we're seeing. It can't just be a wound care-led initiative or a nurse manager-led initiative or a CNS initiative. It really took our entire care team from our CNO and associate executives all the way down to our managers to have those conversations and engage staff and talk about how we were supporting them with leveraging the tool. And those change management principles were really key. So I think with any device or tool or new implementation that you have in your organization, the one thing that really determines that success is going through those change management protocols. So thinking about, do your staff, those ADCAR models, do staff really have the awareness and desire, knowledge, and skills and ability to leverage a tool? Something like the leaf sensor is a really, really intuitive system. There wasn't a lot of training that was needed. It's something that our staff can see and engage in with right away. We provided some education, of course, but very seamless integration for staff. So it was really not about the education for the tool. It was around what is our data? Why are we doing this? How are we supporting you? Why are we going this route? Why are these other strategies not an option or not working? And how can we continue to support the care of our patients? And encouraging them to look at the data that they have every day. The system gives a report each morning called the Daily Impact Report. When we first launched the system, we were so worried about our team's reaction to watching them that we failed to share those numbers. And I think that lack of transparency really created more questions with staff around, what are you doing with these numbers and what does this look like? So being really forthcoming and transparent about their turning protocols. We are not looking for 100% turning adherence, which is kind of a shock for staff. And I think if they're a little bit late or if something happens or they only achieve 90%, then it feels like a failure, right? We're in such a world where we're looking at data and metrics and our staff are really striving for 100%. That's just not the reality with our sick patients. And there's some times where we can't turn them and that's okay. And the system accounts for that. So what the evidence shows us is if we achieve an 85% turning adherence or better, that's when we start to see those reduction rates of injury. So that's what we're trying to achieve. So sharing that data with them and really being transparent about our intent was critical. And then, celebrating small wins. And so there are times where we had some breakthrough pressure injuries, but really looking at the data, learning from those experiences, they're few and far between. And then sometimes what we learned is when we looked at the data that patients had related to their during the period of their sensory utilization and the window of their pressure injury development, we were able to indicate that staff met or achieved the standard of care that we asked them to achieve. And we've done everything within our power to prevent that pressure injury. And so at that point, it becomes an opportunity to say, this was an unavoidable injury. We did everything right. And we can put that documentation into our record and take that risk or liability away from our organization. So really highlighting that, sharing that information when it occurs and celebrating staff efforts and small wins. For our organization, we implemented during a period of very high stress just before COVID, and our readiness and our rate of consistent practice adoption for the new standard was a little bit variable. We didn't have the consistency with our pilot period that we really preferred. That said, we monitored about 110 patients for over about 11,000 hours, and we still had a rate reduction of pressure injuries of over 67%. Once we paused our pilot, because we tend to not pause after pilots and just make them new standards, right? So we paused on our pilot, we looked at the data, and we worked with our care teams to say, here's what leadership is seeing with our data and our numbers, and here's what staff are feeling about the reliability and the validity of the tool, and how can we bridge that gap? And what we learned is that staff really understood and saw the impact over time that this tool had on patients, and were excited to leverage this in their bundle. And after a reboot, we launched this as part of our standard of care. We had the device in place consistently for another 3 to 5 months, and we achieved that level of consistent practice adoption that we're really looking for with our standard. Once we did that, we saw rate reductions of over 82%. We've been in we've been in implementation for just over 3 years. And in those areas, we've seen a sustained pressure injury rate reduction of about 82% in our ICU. One of our medical surgical ICUs had a rate reduction a very high rate reduction and actually went 125 consistent days without a pressure injury in their unit, which was really powerful for them and something they were really proud of until COVID. And then we had our first one, but sustainable low rate reduction. So really proud of the team for leveraging the device and the way it was intended to be used and seeing those great results. So in summary, this tool has been really powerful for us to get the results that we want. It provides that reminder to our care teams, and it takes away something else that staff have to remember, right? It's silent, it's visual. Anybody in our unit can walk into our area and see and understand what those three colors mean: green, yellow, or red, and then take the appropriate action. And so it really helps us, takes away that delegation that teams have, improves that team communication and sense of responsibility around turning. So essentially our whole team becomes a turn team as they see that there's a need and are able to act on that. The system has the ability to interface with any electronic health record. So we are Epic users and have built that interface for integration. And those are the kinds of automations that we really should be looking at in the future for staff, right? To document as much as we can in real time and seamlessly without staff having to go in and manually put in that data to reduce those manual data points. So while it's not the automation that we need for the future of nursing for 2030, it's definitely a step in the right direction and has the ability to do that for our teams. So as nurse leaders, I think it's really important, we're uniquely qualified to think about those change management strategies and support our teams as they launch new tools like this, really intended to improve the outcomes of our patients. So any of our nurse managers or teams, our CNS staff, our wound care team can go in, but without the support of the entire leadership team, really looking at change management strategies, delivering that consistent message, you'll have good outcomes, but where we want is those great outcomes that really impact our patients, and I think we have the ability to do that. So with that, I thank you so much for your time. I'm happy to take questions or share more information about our results specifically. Yeah?
Did you say that you had built-in interface with Epic?
So the question was around an Epic interface, and we have built the Epic interface. There are organizations that have interfaces in place. Ours is fairly new, but we're really excited to see the impact on our documentation. And that one study that was just published this month really looks at what some of those potential outcomes could be.
And then just one follow-up. Do you only use it in the ICU, or do you have a decision-making process about where you deploy it?
Yes, thank you. So her question was, where are we leveraging it now? Is it only the ICU? And it's a fantastic question. We were so thrilled with our results that we decided any unit that had a prevalence rate or a pressure injury could benefit from the tool. So once the infrastructure is in place for the system, it's very easy to expand. And it's actually very easy to put the infrastructure in place. So we are now a LEAF organization. So we have this in every care area of our organization. So we have it in our 2 ICUs, the surgical and medical, our cardiology units, our medical surgical units, our progressive care, and our general care with great results. In fact, our general care unit, they maybe had, it's a small 30-bed, they probably see 1,000 patients a month or so with their turnover. I would say that that unit has not had a pressure injury in the 3 years that they've been live with the tool. Not all of our units have been pressure injury free, but the medical unit has. Yeah.
How much staff do you have on your wound team for the size of your organization?
Oh my goodness, so that's a great question. How many wound care staff do we have for our entire organization? I would say we have 4.5, maybe 6, and I'm not sure of all of their FTE and how much time they support. We're a 350-bed hospital. Our wound care team was instrumental in helping us evaluate the system and identify the right patients for criteria for use. What we have found over time is that we consult them if needed, but our criteria for application is very, very simple. We've gone through several iterations. We wanted to be good stewards of the sensor and only apply it to the patients at most high risk. So we had all of this criteria. What we found it was too complicated, and then we weren't using the sensors early enough. We were putting them on more as a treatment for redness or for skin integrity concerns as opposed to actual prevention. And we weren't adopting this as part of our standard because there was too many rules about when to use it, when to leverage it. So once we did away with trying to be a good steward of the sensor and the dollar and said, this is part of our standard of care, patients meeting this Braden score, whether you're in ICU or general care, are eligible for the sensor. And what we found was more appropriate sensor use, less sensor waste, and more effective cost management, and then better outcomes for our patients. So our wound care team consults initially to help, but the pressure has really been off of them. It's reduced the number of pressure or consults that they have to respond to the injuries, but also they come when we do have a low Braden score, they're notified of the sensor, and they help monitor and track those patients, look for pause time. So the sensor has the ability to pause turning if the patient's undergoing a procedure or refuses to turn for a reason, and you can document those. So you get a better picture in your documentation record of what's going on in your care delivery. And so our wound care team has really been able to focus their attention on that and where they're needed as opposed to serving the greater hospital. So it's really been effective. Yeah.
Explain what kind of tools you give to help with the microterms on the hemodynamic.
Yeah, so the question was about hemodynamic instability and the types of tools we use to support our staff. So what we were seeing was a true fear, right? Hemodynamic instability is scary, particularly to newer nurses or nurses who haven't really experienced that. And the data tells us that we have to move those patients. The only way to combat hemodynamic instability is with movements. So we're fortunate enough in our organization to have clinical nurse specialists and a CNS team. We also have our educator group dedicated to each area. And so based on the data that we were seeing in the daily impact reports, we were able to launch a series of quality improvement actionable items based on that data. So when we saw that decreased churning rate or documentation that there was hemodynamic instability or a do not turn order in our record, which would really make our hair stand up and give us pause, then our CNS team would launch and they would go in and they would work side by side with the care team to provide that education to staff in a safe way, to say, this is what we're going to see, this is what we're going to experience, this is how comfortable, or this is when to become uncomfortable with the numbers that you're seeing, and really work one-on-one, side by side, to have that clinical expert and notify the physician that there was instability, and then do those reassessments. So a lot of times these would be new surgical patients, and they would have one episode of hemodynamic instability, but we were so frightened by those results that we were afraid to do that assessment. And so they would come in more periodically, do those assessments for our team so that we could reset those angles and really individualize that based on the patient's need. And so I don't know if that answers your questions, but it was just a lot of clinical expert support at the bedside.
Yeah, we're piloting it right now and we've had good results, but there's a lot of nervousness in regards to the ECMO patients or some of the other patients post-open heart that are clinically not doing well. And these are the patients that are at risk for critical ulcers.
Mm-hmm.
How do you kind of challenge the team to say, we just need to try?
Yeah. Absolutely. So that's when we would launch a consult with our wound care team and have the CNS come to the bedside and work together is this patient a candidate? And sometimes the answer is, you know what, this device might not work for this patient, but most of the time the sensor is appropriate, and even those microturns can really help. And we know with microturns that we often don't really, provide reperfusion to the areas that we need, right? We think we're microturning, or we're just moving that shoulder, and that counts as they've been repositioned. And so it really helps us achieve those better results. And then it gives us the hemodynamic numbers for each turn angle that really gives us a better picture clinically of what's happening with the patient. So yeah, it's a challenge. And you're not, your organization is not unique in that, but you can use that data with your care team in a transparent way to launch those safety protocols to say, when we see this, then this action will happen, and that will really help achieve those results. Yeah.
So I assume that they're attached with adhesive like a EKG electrode.
Mm-hmm.
How often are they recommended to be changed?
That is a great question. So the questions around how the sensor attaches and then how often it's changed. So this is really in most cases, one sensor per patient utilization. It does have an adhesive backing, very much like, a tegaderm type backing. It's radiographic, so for your daily chest x-rays, it doesn't have to be removed. Now, we do recommend that it's removed for procedures if the patient has to return to the OR, or for MRI, scan. But when you remove it, it can simply be reattached, with a tegaderm if you feel like the stick is lost. But we don't even do that most times. The stick is, it adheres well. Another question I get a lot is if we've had injuries related to the sensor, right? So does the sensor cause injuries or breakdown? And I thought that was a great question, and I worked with my wound care team. It's something we track. In the 3 years that we've been live with the thousands of patients we've used this on, we had 2 incidences, and they were on the same patient, and it was related to improper removal. So we have a technique for how we prefer to remove the device, and this was one of those like little old ladies with some extra skin, and we didn't remove the sensor per our standard, and created a little micro tear. But no pressure injuries related to the device itself. It's maybe an ounce, and my vendor partners could give you those specifics. Maybe it's more than an ounce, but it's very lightweight and unobtrusive to care or to the patients. They barely know it's there. Another nice feature, particularly with COVID and isolation, is that it's real-time feedback when the nurses are doing that turn, so they know right away if they've achieved a quality turn angle. But it's on a screen, so they don't have to go outside of the room or to a monitor to see that that's been achieved. There's a light on the sensor that you can't see in this picture, but it lights up to give you that indicator that you're in a quality position, or it would give you a red flashing if you're not quite there and need to adjust the patient. So the education that we talk about, it's not with the system, it's not really with the device placement or removal. The education that we struggled with the most in our unit, which was why that change management was really important, was that we realized that as a profession, we have migrated away from what a true quality turn is, and a lot of our nurses have just forgotten or haven't received the education on a quality turn. So unless we're bending that knee and turning the patient, we're not really getting the core turned, and so we're not getting full reperfusion. And as a healthcare provider and as a nurse, and we all want to do the right things for our patients always, right? It's a really difficult message that you've been providing suboptimal turning for 20 years in your unit, right? That's a difficult message to receive. And so it takes a lot of practice and encouragement and support to encourage our nurses to think differently about what the patient looks like in the bed and what comfort looks like. If you've ever put a patient in a 30-degree angle, you know that they're really turned and it looks like they're not comfortable. Now our patients don't report discomfort. In fact, many of them like it if they're able to verbalize back to us. But we have to reframe that in our mind of what a quality turn looks like, and if our patients are comfortable, and that image we have of our patients in the bed. That was the biggest challenge we had to overcome. So, all right. Well, thank you so much. I appreciate your time this morning, and happy to be contacted as questions might come up and share more data about what we've been able to do in our organization.